Hello, everybody. This is the Standing Committee on Health and Social Development. Today is Wednesday, January 20th, 2021. And I'd like to welcome all our members here today. The committee members, Zach Bell, Heath McDonald, Hannah Bell, Brad Trivers, Trish Altes, and Ola Hammerland's visiting or sitting in for today. First, can I get a motion to adopt the agenda? Oh, certainly.
Yeah, thank you, Chair. So I have a question about the agenda. It seems to have changed from what was originally scheduled for today. We were supposed to also be talking about safe injection consumption sites and hopefully harm reduction more broadly. So why was that change made?
That change was made to make sure that we just focused on this, or that we were talking with the clerk. And yeah, go ahead.
So I did set out a revised notice and revised agenda, and that's just to give them a separate date to speak on that matter. So they're going to come in on the 10th to speak solely on that.
Trish?
Thank you. So I saw the revised agenda and the note, and thank you for sending that, Alicia. Can we just get some clarity, though, on why that change happened? Was that a request from the presenters or the chair or the minister, or how did that come about? It was very last minute.
I believe it was just to give both presentations the justice that it deserved.
Yeah. Sir, Josh?
Yep, and I mean, I can definitely see the logic to that. I just want to understand what happened because, you know, obviously we were prepared to ask questions about safe consumption sites. It's a topic that is very important with increased, we know that addictions and mental health is a very serious issue and we want to look at options around harm reduction right away. So just sure. Wondering, you know, again, for clarity, who decided that we should talk about that on a different day? And is it scheduled for another day then already? Okay.
Yeah. So it's scheduled for February 10th, and we'd get into that with the discussion of scheduling. But yeah, your point's valid, and you're absolutely right. It doesn't mean that the topic is any less important. For sure, it's very, very much important. So it's just some logistics that we worked on. Yeah, Trish.
Thank you, Chair, and I appreciate the clarification on this. Just so I understand, so we will have Dr. Morrison coming in again, as well as Erin Bentley. I'm not sure on February 10th. Is that the plan? They're both coming back?
Yes.
Yes, and possibly we have epidemiologist as well, and that may be sitting in there.
And I believe the minister is also going to be making that appearance as well.
Okay, thank you.
Yeah.
That's all.
Thank you very much. And the minister's not here today. He's sick. So we'll move on to. Did you adopt the agenda? Did we?
No.
No. Okay. Okay.
The agenda following the
Hannah.
discussion.
Okay. Perfect. Thank you. Hannah Bell is moved to adopt the agenda. We'll move on to number 3. We're going to get a briefing on the rollout for COVID-19 vaccines. So our guests today, I'll pass it over to our guests, and they can introduce themselves for Hansard and then continue on with the presentation.
Hi, everyone. I'm Heather Morrison, and Erin Bentley, who's our Senior Policy and Planning Coordinator or Policy Officer, as well as Manager of Communicable Disease for the Chief Public Health Office. We're pleased to be here, and it wasn't really too long ago. We actually were recalling it was, we were in to speak about immunizations. I believe it was September, and it was a beautiful, beautiful day out, and so we were reminiscing. It wasn't too long ago that we were both here, and so we're pleased to be back. And in many ways, some of what we'll be talking about is not that dissimilar from our presentation in September, but it's exciting to be here, the beginning of 2021, speaking in more detail about the COVID vaccine. And I think we're pleased to be able to do that. We will be back with the team in a couple of weeks to speak about harm reduction and safe injection sites. So that is definitely on our agenda. So today we're going to start with a little bit of our epidemiology, which I think sets the tone for why the vaccine is so important. and then move into the actual vaccine rollout and what we know about the vaccines available here in Prince Edward Island. We have around 94 million cases reported globally of COVID-19 and over 2 million deaths. And of course, those numbers change every day. In the US, 24 million cases of COVID-19, and they have already recorded around 400,000 deaths and are expected to have another 100,000 deaths in the next month alone. In one day last week, a third of the new cases in the world were reported in the United States, and followed by both Brazil and the United Kingdom, with large numbers of cases and deaths. We have in Canada, we also have a large number of cases. We have over 715,000 cases and over 18,000 deaths recorded at this point in Canada. And we have based on the testing that we've done in the country, we have a 4.4% positivity rate in the country, and that compares in the US with just over 5% positivity rate. We've seen a 14% increase in cases last week compared to previous week, and we also and I'll speak about hospitalizations and ICU in a minute. We know, and I think this first graph, I think you can recognize that during the first wave, when you look back in April, this second wave certainly exceeds that first wave significantly. We've said right along that this, and I believe we said back in September, we expected the second wave to be worse than the first, and that has proven to be the case, both in terms of cases and the rates of hospitalizations and deaths. Hospitalizations and ICU admissions are rising across Canada. 7.5% of our cases are hospitalized, and 18.3% of them need ICU admission, and 3.6% require mechanical ventilation. 89% of the deaths in this country have occurred in those over age 70, and 96% of the deaths in the country have occurred in those people over age 60 years of age. 71% of our hospitalizations have also occurred in those over 60 years of age. And what was interesting about last week is that the incidence over the last couple of months has been primarily highest incidence in those 20 to 29 as well as 80 to 89 years of age. And last week we saw a slight change that the highest incidence age groups were 20 to 29 as well as 30 to 39. Some of you may have seen the Public Health Agency of Canada modeling that came out at the end of last week, and showing as a country that without putting public health measures in place and restrictions in place as a country, the number of cases will continue to increase. And how the model looks is if we really want to curb the rate of COVID-19 in this country, we'll need to decrease our rate of contacts by around 25%. And that's why you'll see other provinces really putting measures in place to try to reduce that number of contacts. We have outbreaks which have primarily been reported in long-term care and community care for seniors across the country, and particularly Ontario and Quebec, which account for the largest proportion of outbreaks. But we've also seen outbreaks in schools, daycares, correctional facilities, food and retail, healthcare facilities. So really outbreaks have been reported in athletic or gyms and teams that have been playing together. So really outbreaks have occurred in various settings right across the board. Now I think people hear enough about our COVID cases in Prince Edward Island, so I'm going to go right into our vaccine distribution model, and some of you will recall this from our previous presentation in September. Immunization programs are coordinated in this province provincially through the PI's Chief Public Health Office, and Vaccines for public programs are shipped to PI and received and stored at a provincial pharmacy. We know that the childhood program is administered by public health nursing, and adult immunizations are given by different immunizers across the province. These are public health nursing, physicians and nurse practitioners, long-term care and community care facilities. Vaccine goes to those facilities, as well as community pharmacy. And the largest number of doses of vaccine, of course, is administered usually in the fall of every year when we do influenza. And this year, close to 80,000 doses of influenza vaccine were distributed over a period of 2 to 3 months. And so one of the busy weeks in the influenza season, they gave 11,000 doses of vaccine and were administered in 1 week. So that gives us a sense of what we're able to do if we have vaccine. And so that's why I mentioned that. And also the importance of our partners there. I put this up here because I think it reflects some of the national work around vaccines that is going on. And this is just the ones that we're involved with. It does not speak to Health Canada's involvement with the approval process. Vaccine. I sit on the National Special Advisory for COVID-19, which is led by Dr. Teresa Tam in conjunction with the Chief Public Health Officers of the country and other public health experts. Beneath that, we also have the Technical Advisory Committee, Logistics Advisory Committee, both dealing with COVID, as well as a variety of our immunization groups. So we have Vaccine Supply Working Group, Canadian Immunization Registry Committee, Canadian Immunization Committee, Vaccine Vigilance, and the National Advisory Council on Immunization, or NACI, and you may have heard us speak about NACI. There's also the First Nations and Inuit Health branch, PT working group. And we have representatives from PI on many of these groups. Here in PEI, as the vaccine we knew it was coming in preparation, the steering committee was established with a logistics working group, clinical working group, and data management and reporting working group. We also have First Nations COVID vaccine working group comprised of health partners at Lennox Island, Abbotwood, Micmac Confederacy, and Atlantic representatives from First Nations and Inuit Health Branch, which certainly will all work together to determine the COVID vaccine programming for their communities. And then there is a consultation group as well for priority population sequencing that has been established and will change composition as we go through the next number of months. And that role of that group is really to assist in sequencing groups within priority populations for receiving vaccine. So for instance, at this point in time, representation from Health PI as they're looking at their healthcare workers being important for that group. We have 2 members of Canada's Armed Forces with expertise in planning and logistics, which are on the steering committee and have been assisting us. We have, and really wanting to speak about some of the membership of the steering committee. So the 2 of our members of the Canadian Armed Forces, along with our epidemiologist who deals with immunization. And we have logistics representation, provincial pharmacy, ITSS. We have our provincial immunization coordinator. We have Erin Bentley with senior policy and planning, and public health nursing, health PEI, and the deputy chief public health officer, and myself making up that committee, as well as communications. So as we look to have a population level immunity to COVID over the coming year, it's really laid out in different phases. And this first phase we're in now, we call it Q1. It's been referred to even nationally as Q1, and that takes us to the end of March. And then the second phase between April and June, or Q2, and then phase 3 being the July onward. And there are different tracks of vaccines in these different phases. So we know, and I'll speak more about the Pfizer and Moderna vaccines that have been approved for use in this country during this phase 1. And as we move into Q2, you'll see both those vaccines, Pfizer and Moderna, but the anticipation of additional vaccines. Canada has signed 7 advance purchase agreements for a variety of COVID vaccine candidates, and these different phases really are defined by vaccine availability and trying to get certain groups offered immunizations, and more vaccine is expected to be available over time. PEI is being allocated about 0.4% of Canada's vaccine supply based on our population. And certainly all these factors coming into play in terms of logistics for shipping, storing, and how much vaccine we're going to get will inform our ability to offer vaccine for our different populations. It is, and I'm sure you've heard me say this different times over the last number of weeks, everyone in PEI who wants to be vaccinated will have a chance to be vaccinated. And we're going to do so as quickly as we possibly can, and we all want that to happen. And I think everyone is anxious to achieve a certain level of herd immunity. And you'll see different provinces, and even nationally, talking about different levels of herd immunity. I believe with our certainly high level of immunization rates in this province historically, that we can achieve an 80% uptake rate in our adult population. And I think that will be certainly the goal, and we'll continue to work on that. There is some discussion nationally as they see more variants of COVID-19 that it will be very important to help suppress COVID and the pandemic if we achieve a certain even higher level of herd immunity in terms of making of the vaccine and coverage. So that will be important, and we will watch that. You might need a slightly lower herd immunity if you were not as concerned about variants. But we'll learn more about that, about variants in the next little while. There was initial information released recently about the susceptibility of the Pfizer vaccine to the UK and South African variants, but that information has yet to be peer reviewed, and but that's certainly initially good news. I might just mention here, we've said this before as well, vaccine is a really important additional measure for this global pandemic, but it is not the only measure, and a lot of our public health measures will remain important as we go through. The next slide, I won't take too long here, but because this is really for those who have an interest in some of the science around messenger RNA vaccines. Both Pfizer and Moderna are mRNA vaccines. And when we talk about the mechanisms of action, RNA is very sort of unstable on its own, and it's broken down by enzymes in the body. And so companies can use techniques such as modified nucleic acids and customized formulations to try to increase stability. RNA only needs one membrane to cross, and therefore RNA can be delivered via a lipid coating, which is commonly referred to as a lipid nanoparticle. And the reason I'm sort of mentioning all this is that because we've had some questions, RNA only enters into the cell for translation alone. It does not enter the cell nucleus, and so there's no risk of the RNA integrating into a person's genome or DNA. And some of the benefits of messenger RNA vaccines, it's faster manufacturing and interchangeable antigen, and it can adjust more quickly to new variants if needed, for example. And it's certainly anticipated activation of cellular and humoral responses, which will result in good protection. So that's just sort of a little bit of background, maybe a little detailed. I'm going to move into the Pfizer messenger RNA vaccine, and it was the first COVID vaccine to receive approval in Canada. And it's also the most challenging from a cold chain point of view. Most of our vaccines are normally stored at 2 to 8 degrees in a fridge temperature. Of course, this one is shipped and stored at minus 75 degrees. And Pfizer, it's a little different. Pfizer is shipping the vaccine directly from the site in Belgium, basically to PEI. It is not like Moderna, where Moderna is shipping it centrally to the country, and then Canada ships it to our provincial pharmacy. For those first shipments, Pfizer required that the vaccine be delivered to a major hospital that would serve as a clinic administration site because they didn't think it could be transported at all from its point of delivery. And so that's why the initial clinics were at the QEH. But starting in January, the vaccine was allowed to be transported even once it was thawed for up to 12 hours. And now, as you know, it's being used in long-term care and community care facilities for staff and residents in the Queens County area. We have been holding back the second dose for the most part so that we can make sure that we are able to vaccinate people 21 days after the Pfizer vaccine, recognizing that the Moderna has a 28-day interval in between the two vaccines. You may have heard recently that NACI, I think it was earlier last week, came out with an updated statement saying as much as possible stay to the product monograph of Pfizer and Moderna to its 21 to 28-day second dose, but they have said for epidemiological reasons, logistical reasons, that second dose interval may be extended up to 42 days. And so that is relatively new, and you may have heard some comments or questions about that extended dose. As you know, Pfizer has contract 20 million doses altogether for Canada, and based on how much they will anticipate getting in by the end of March, our allocation for PEI will receive enough vaccine to have over 16,000 doses, almost 17,000 doses of Pfizer in Q1. The Moderna vaccine is, again, based on the same mRNA platform as the Pfizer vaccines, and it will be delivered to our central storage location and stored at minus 20. And vaccine can be distributed while frozen to other clinic sites across PEI and is stable in the fridge for up to 30 days. So 2 doses, 28 days apart. Canada has a contract with Moderna for 20 million doses in total. And in this Q1, or this first quarter, PEI is expected to receive enough Moderna to immunize, or enough Moderna doses of sort of 7,000 to 8,000 doses of Moderna. So at minimum during Q1, we'd expect to vaccinate between sort of 12 to 15,000 people in Prince Edward Island, based on our vaccine supply. Vaccine, in terms of side effects, they are commonly, and we're starting to have some of these because we have, it tends to happen more often in the second dose. And so some of our healthcare workers, for instance, who've had second doses have reported some of these side effects that they've seen in clinical trials. So these are systemic events: fatigue, headache, chills, muscle pain, and joint pain. And they tend to be reported more in younger age recipients, so the age 16 to 53. And that really has to do with the immunogenicity, the antigen binding and neutralizing antibodies in the studies really are dose dependent and higher in the younger versus older cohorts. And it's not unusual for vaccines when they're first on the market at approval time that they don't know how long the immunity lasts, and I think you may have also heard that discussed. How long is the COVID vaccine going to protect us over time? And we we don't know all those answers yet, and that will come as we learn more around the world. And the strength of immune responses in the general population sometimes is not known when a vaccine is approved. Again, this is not unique to COVID-19. In terms of our guidance for phase 1 program, it's really based on the NACI guidance for the prioritization of initial doses of COVID-19 vaccine, and we have been trying to follow that in our vaccine rollout in PI, at least for this first quarter in Q1. In fact, some of what you'll see here in terms of our groups, NACI has said you can wait till quarter 2, or they put them in Q2. We think we can bring them in a little bit sooner and do some of them in Q1, and I think that highlights our desire to get as many people done as soon as possible. So residents and staff of congregate living facilities, so we are going to be moving into those congregate living facilities, which include shelters, group homes, other residential facilities. We know we're doing healthcare workers with direct patient contact at higher risk of COVID exposure. We've already talked about our long-term care residents and staff. And we are, based on the numbers of anticipated vaccine that we're going to get in Q1, we are hoping to start immunizing those people 80 years of age and above. And I think that we're very hopeful to be able to do that. We also are going to be starting to do partners in care. And those, we may not get all partners in care, because a number of residents have multiple partners in care, but we will start getting those partners in care as well in the Q1. We've talked about rotational workers and truck drivers. They are certainly essential workers that we're hoping again to bring into Q1 because of the importation risk. They're in and out of high-risk areas frequently. And it's interesting, I heard a couple of the other Atlantic provinces speaking in the last couple of days about also trying to include rotational workers. And I know I had certainly spoken to them about our desire to do that as well. There won't be enough to vaccinate everyone right in the beginning in PI, and we are trying to follow the national recommendations as much as we can. And just before I forget, when we go back to talk about those, the side effects and about how the unknowns at the time of when we had to give vaccine, it also speaks to what we don't know about asymptomatic transmission of the vaccine. And so even the studies really are about making sure how you are protected from symptomatic disease and severe outcomes. But what they don't know is how well the vaccine will protect you from possibly transmitting the virus without any symptoms to someone who may not be vaccinated, for instance. And they are going to, again, learn more about that and in the weeks ahead. So continuing on with vaccine supply projections, the vaccine supply of Moderna and Pfizer is projected to reach 1 million doses per week in April and 2 million doses by mid-June. And so we'll expect to receive 4,000 doses per week in April and increasing to 8,000 doses per week in June. And that is, and just to remind people, that is without any additional vaccine coming on the market. So if we get additional vaccine approved, such as AstraZeneca, and it's available for this country, then we would have additional vaccine as well. We are still on track to have our long-term care and community care residents done by the end of this week. I know there are questions because of what happened at Chez Nous, but we're working out those details as best we can. And then we would have all the second doses done, anticipated by February 16th of our long-term care and community care facilities. We are making sure there's equipment coming in from the federal government about everything from gloves to additional freezers. We're working with Health PI in terms of our immunizers, and also making sure, for instance, our home care nurses are immunized in order to go out and vaccinate residents who may be awaiting placement into long-term care, so that it's not just public health nursing who will be doing it, but also employee health nurses helping out in facilities, for instance. We will be looking, as the vaccine doses increase, to more mass immunization clinics and partnering with community pharmacies, and that discussion is ongoing. In track 2, so that's the spring vaccine. We'll anticipate getting more vaccine, and the vaccine supply will start to approach the demand in phase 2, and that will be great for everyone. And we will be, as mentioned, working with a variety of immunization partners, and with the anticipated other vaccines that may be coming on the market, they have, for instance, pharmacies are used to managing cold storage and administration of a delivery of a vaccine that's in that 2 to 8 degree range, because that's what they're familiar with. And so we anticipate and hope that the next vaccine may be in that, will have those kind of storage requirements. For phase 2, I think I said this yesterday, and I'll say it many times, that everybody is important, and we will continue to emphasize that going through. For phase 2, any groups remaining from phase 1, for instance, as adults 70 years of age and older, 65 years of age and older. As mentioned earlier, age is such a strong indicator of severe outcomes that the rest of the provinces are starting to look at trying to focus on age as opposed to other factors. And I think there's been lots of discussion about pregnancy, immunocompromising conditions, autoimmune disorders, chronic conditions in general. And I think we are very conscious of lots of people reaching out to us, and knowing that we want to address all of these groups, but age certainly being the predominant of predominant importance as we try to get a vaccine rolled out to thousands of people as quickly and efficiently as possible. Are those, of course, we know in terms of chronic conditions, we do have more chronic conditions with people who are, as the age goes up. And in track 3, it is summer, and I think we'll have a lot of our groups vaccinated by that time if vaccine supply cooperates, and and this is when the supply of vaccines is expected definitely to become much more available, and general public will be available for the public. And then we'll also be looking to see if during that period of time, if we have children may end up getting approved for vaccine for approval, but that'll depend on some of the clinical trials that are ongoing. But at this point, and I didn't mention that earlier, these vaccines are approved for adults only, and but that may change with these vaccines, but it also may change with some of the additional vaccines coming on board. Just to maybe almost finish off, I think the recording and reporting is there, but the public health measures, I guess I'll speak about that first, and the vaccine program. I've mentioned already, we don't know the duration of protection and the efficacy to prevent asymptomatic transmission. I mentioned both of those, and that age is the highest risk factor in severe outcomes from COVID disease. And because I think people want to know, well, if I've gotten my vaccine, do I still need to wear a mask? And that's a very understandable question. But at this point, and NACI is very clear on that, at this point in time, people need to continue to wear a mask and practice the other layers of protection so that we don't make others sick unintentionally. And I think as in order to suppress COVID-19, I said it earlier, we will need to try to achieve a certain level of herd immunity, as well as continue with these public health measures so that we really don't have to worry as much about COVID as we go through. And some of the things we're doing now will mean we can get back to big sports events, visiting people in a different way and not wearing a mask someday. But right now, even though the vaccine is here, we can't stop some of those things yet. Recording and reporting. We have a COVID Immunization Registry, and I think that's important. These rates are reported weekly to the Public Health Agency. And we are working on making sure our COVID vaccine program webpage is getting updated and will be useful for people. We also have surveillance of a reporting and of any adverse events after immunization, and these are these APHEs, adverse events, and they are required to be submitted to the Chief Public Health Office and subsequently to Health Canada for national APHE surveillance and tracking. There's work underway for online scheduling of appointments, and I know that will be really important as the number of people increase in terms of making appointments for vaccination, and so that is ongoing, and we should hear more shortly about how that appointments and scheduling is going to work. And the other question that keeps coming up, of course, is proof of immunization. And we have, people are able to, everyone who's going to need a piece of paper that says they have had their COVID vaccine here in PI can do so. But what we're waiting for and nationally having the discussions about is what is Canada going to require for people entering the country, if they're going to enter, what will Canadians need to show that they have been vaccinated, and what's that going to mean even interprovincially, because it's important not only for islanders to have proof of immunization if they need it, but what is that going to be recognized elsewhere, and what are we going to be asking for in terms of proof of immunization. I know that this is an active conversation nationally, and we're certainly talking about it here as well. We're fortunate in that we actually had, and we mentioned this I think in September, we already have immunization regulations in place that mean that every vaccine of all kinds has to be recorded and reported in this province, and so that's already set up. So we'll continue this with COVID, but I think it's there's lots of and this is not just happening here; it's happening around the world. There's vaccines that are required for entry into certain countries already. But that has not been a decision yet, and about entry into this country, and we will be following that closely, what's happening there. And I think that might be, that's it. So I tried to go through all that, and we can speak about specific questions about the vaccine here, but I thought I'd leave lots of time for questions.
Thanks a lot, Dr. Morrison. Great presentation, and we'll take questions. The committee will try to keep it to 4 potentially. Is that okay? 3 or 4 in that area, and we'll just do a couple rounds. So we'll start with Hannah and then Trish.
Thank you, Chair. Thank you, Dr. Morrison. It's nice to see you again. Just a couple of follow-up from a couple of things that you mentioned in there, if I can. You'd mentioned that you are hoping to do all sort of the group homes or sort of congregate living facilities that are hopefully in phase 1, which is great. I have asked specifically already through other routes as well about residents and group homes, particularly like LifeBridge, Stars for Life, and can we hope that those are going to be included? Fantastic. And the other one was the K. Reynolds Centre had also reached out, which is not necessarily congregate, but there are congregate facilities. So I mean, it gets a little grey there, but.
We'll take, I know Erin has been, have requested the administrators and the staff, and we're getting all that information so that those appointments can be set up. We'll just take note of the K. Reynolds, because I'm not sure it's been included or not, but the other Stars for Life, yes.
That's great to hear.
Yeah.
Hannah?
Thank you, Chair. A follow-up from that is Pat and the Elephant Services are actually run out of the K. Reynolds Centre, but I know the staff at Pat and the Elephant Services, have to get up close and personal with clients in terms of assisting them, particularly in and out of the vehicles, in and out of facilities that they go to. I'm just wondering whether we could consider including them in that essential other health worker space. Even though they're not officially health workers, it's part of and parcel of the work that they do, and often the drivers and the people who do that work are seniors themselves who are potentially at risk, and so that's been a concern that's been raised, that perhaps just to take this opportunity to get it on your radar.
No, and I think, and those are exactly why they would be identified in this, in the Q1, Q2, trying to get all these vulnerable groups, either who are at risk of developing severe disease or of or who are needed for our services here, to have all of those done by the end of June. I mean, that would put us in a really great position.
Hannah?
Absolutely, and sort of recognise that there's so many additional things in this, just in terms of logistics and so on. But the other question, and I apologise if I missed this in the presentation, but can we have some clarity on what we think may be happening for vaccination for children?
So at this point in time, it's not. Pfizer and Moderna have not been approved for use in children, to vaccinate children, and often, as with additional trials and additional studies, then that information is submitted to Health Canada for increased indications. So once those indications are considered, whether it's for Pfizer, Moderna, or a different vaccine, then that's when the statement is updated and the product monograph is updated as well. So and often that will, they don't often do trials on really young children, but so this will be over time where that information will become available. So is that what you were?
Yeah. Chair?
Hannah?
Thank you for my follow-up, my fourth question. Thank you. I guess the concern is, you're talking about herd immunity, and obviously we want to try and get to that kind of 80%, but that's 80% of the adult population. So we're talking 20,000 islanders who are under 18, and it really just shifts the dynamics, particularly when we think about things like school activities and sports and so on. So I obviously understand the limitations, but I think for the public to understand that we actually don't have necessarily a game plan for that right now, and that really does affect sort of the length of time that we're going to need to be thinking about, like you said, those other measures. Because one of the things that I'm hearing, understandably from a lot of constituents is just, won't it be great when, but that's not going to look the same for children potentially as it would do for adults, and we need to then still think about those bigger health procedures. This is as a parent of somebody who's desperate. I think we all get that too, right?
We also know that our children have tended, for the most part, have the transmission of COVID has tended to go from adults to children. So if we are limiting the disease in adults, it will also mean that it's not being transferred to children. So it is, and I'm glad to clarify that, it is 80, our goal would be, up to 80% of our adult population, and aiming closer to 100,000 islanders, and over time.
Excellent. Is it all right to move on and come back? Okay.
Thank you.
Trish?
Thank you, Chair. And Dr. Morrison, thank you so much for being here today and for this presentation. Obviously, the distribution of vaccines and what it will eventually mean for getting back to normal, and this step is something, a topic of great excitement and hope for many Islanders. So being able to be here to ask you questions about this, I consider that actually quite a privilege, and I will try to relay some questions that I've heard from constituents as well. So you mentioned that there will be others beyond the public health nurses who will be involved in the distribution at different phases. So can you tell me, first of all, pharmacists, at what phase will they be involved?
And I'm, thank you for the question, because I may not have made that clear. Really, in our discussion, we've been speaking with the Pharmacy Association, for instance, and really it's when we get more vaccine in the province where we are moving into, and we're having discussions about what that would look like. And so I mentioned, so it'll be likely in Q2, or that second quarter, when there's additional vaccine. And also looking at what vaccines, if there's another vaccine that comes on the market that's able to be stored at the 2 to 8 degrees Celsius without the super minus 80 freezer, and because those are those will also be logistical considerations, but certainly the intention would be also to have physicians, nurse practitioners help in mass clinics, for instance, and I mentioned different nurses through the system, and in long-term care and community care, nurses helping, and they have already been doing that. So it's primarily those partners at this point.
Trish?
Thank you, Chair. And you also mentioned that home care nurses will be engaged to administer vaccine for, particularly for those awaiting long-term care. And I'm wondering if you could highlight when they will start being involved, as well as will dentists be involved? We heard that recently in the media as a possibility.
The home care nurses have already started being immunized in order to help that rollout in the community. We've started with home care nurses in the Queens County area, and that's plan is to move out to home care nurses in the other areas. And in terms of dentists, I mean, at this point in time, based on the vaccine that is coming for the next few months, we really feel that our system can with the physicians and pharmacy, will likely be able to immunize the islanders that need to be immunized, but we certainly appreciate the dentists having made that offer, and so at this point in time, and I think it refers back to the fact that we know we can do at least 11,000 doses a week, and more with using pharmacy physicians and public health nurses, but we do appreciate that offer.
Trish?
Yes, thank you. So in phase 2, you had highlighted in your slide essential workers, and you had police and firefighters, so first responders, which is wonderful to see. I'm wondering about other essential workers. So, for example, service workers, so grocery store clerks. Are they involved in phase 2 as well?
So one, and I think, again, I'm glad for the question, because they initially, NACI had just referenced all essential workers. And I think they're going to be moving away from some of that language around all essential workers, because it's and focus more on age. And now, having said that, we would like to still not, there's certain essential workers that we are able to easily identify, like our truck drivers, our rotational workers, fire, police, and utility workers. And, but recognizing there are so many people that are essential, large numbers of essential, and we've had lots of people write to us to make sure we don't forget them as essential, but it's really when we focus on age, we will get it efficiently through some of the age too. So I anticipate there'll be more direction on that nationally as well from the National Advisory Committee on Immunization. So we'll be awaiting that further analysis as well.
Trish?
Yeah, thank you, Chair. And, along those lines, I think about, we had, when we had that sort of small outbreak that caused the circuit breaker before Christmas, we saw there the vulnerability of, service workers and for themselves as well as possible spread to others. Now, recognizing, what you've clearly, told us here today is that there's no guarantee that the vaccine will prevent someone from spreading COVID, is my understanding from what you said. And you can correct me if I misunderstood that.
I think what they don't know at this point in time, so in terms of asymptomatic transmission, so they're learning more about it, but it can, certainly symptomatic outcomes of disease have been what has been studied in the trials. And the trials were not based on asymptomatic transmission.
Trish?
So practical question then, because of course, that would inform decisions, I'm sure, around prioritization of vaccine moving forward. Are there any anticipated timelines for when that might be more likely to be known, or how much time is needed to sort of have that information available? Like any idea?
I mean, I think there's some countries who are a little bit, may have a little bit more information a few weeks ahead of Canada and the U.S. So I think I don't have a timeline for it, but I know it's being actively looked at. And I mean, this is a new vaccine, or a new thing to be doing COVID vaccine in the middle of a global pandemic, and so there are no doubt there are challenges to putting this out, but it is at the same time. I think it's a really great place to be talking about it, and we will get everybody done, and we will ask for patience as we do that. And we're not unique, and the whole country, the whole world is in the same position, really.
Trish, last question.
Yeah, no problem. So you mentioned, Dr. Morrison, about the goal or the expected goal of reaching 80% for adult vaccination, which would be sufficient for herd immunity, which would be wonderful to reach. And the fact that we do have high vaccination rates overall in Prince Edward Island. Of course, for something like the flu vaccine, which would be sort of similar in that it's something with a limited timeline that is administered within a short period of time, I guess, that we're not at 80% rate for flu vaccines. So that is certainly the hope and the goal, and Islanders that I speak to are absolutely looking forward to having access to the vaccine. But it is still an unknown of how that's going to unfold. So at what point would you be considering mandatory vaccination? When would those discussions be triggered?
So, I mean, across the country, there's been no indication about mandatory vaccine. We certainly recognize there are some people who cannot be vaccinated. Those who are vaccinated but can't mount the same immune response. So, I mean, we're reporting our rates on a weekly basis, so it's something that we'll be paying attention to as we go forward. We've talked about here last time in our childhood rates, excellent uptake of vaccine, 94%, I believe, of measles-containing vaccine. Which is really great. We have high rates of our school-age-based programs, high 90s% for our grade 9 vaccines, for instance. So I do think if there was ever a community that wants to look after each other, it is Prince Edward Island and Islanders, and I think they will, I really, all the way along through the COVID journey, they will want to protect themselves and also protect the community. And I really feel that that's the case. And I don't anticipate us getting to a position where we would be having to have that conversation about mandatory vaccine. Please jump in, Erin, too, if you ever feel.
Can have a drink. Perfect, thanks, Trish. Zach?
Thank you, Chair. Again, thank you, Dr. Morrison, for coming in and give us a great update. I know this is very fluid, and there are a lot of kind of things that you have to decide along the way. This is just a question with regards to rotational workers. If they were to get the vaccine, I know you mentioned earlier in your remarks about we're still going to be wearing the mask, still practicing proper sanitation and social distancing, but has it come up that maybe the 14-day isolation period would be adjusted or looked at?
So that's a great question. So we have started talking about that, and if a rotational worker or is fully vaccinated at least 7 days post-vaccination, then what we would start off by doing is maybe changing the isolation requirements, because they do have a modified isolation, but changing that and just requiring some testing to make sure that they don't have that asymptomatic transmission, until we know more. Back to your question, so we would continue to test, but then they wouldn't have the same isolation requirements, and that's certainly our thinking at this point in time. And then hopefully, then we would be able to just stop the testing altogether. So I think that's, and I think that would be great for, because it signifies, that we do want to make a change and that we are moving in that right direction. And I think that wouldn't just apply for rotational workers, but that will be a first group. The other thing about the rotational workers and truck drivers, that we will start to vaccinate hopefully in Q1 or by the end of Q1. One of the challenges may be trying to arrange the second dose, because they need to be back in the province for the second dose. So there'll be some scheduling, and so that will happen over time, and they will be registered. So.
Zach?
Yeah, thank you, Noel. That was great. I guess my last question, and maybe this has already been answered, kind of touching on what Trish had mentioned with regards to the essential workers. I know that educators are kind of firsthand with a lot of people in run of the day. When it goes to the general population, when you're able to get to that, is that going to be age as well, or? And again, maybe you have answered this already. I'm just kind of curious as to. Because it's a big part of the population. I'm just kind of curious if you have here's how we want to do it.
I think it is evolving and it's changing. I just think of where we were a month ago with this vaccine, and the first dose is just coming into the province. So at this point in time, we're having the discussions about trying to do a lot of it age-based, at least down to age 50. But I think that hasn't been confirmed yet, but certainly that's part of the thinking, and then opening it up to, by that time, the anticipation is that we'll have enough vaccine that everyone can get it. Ideally, we would be in a position where we don't have to do any sequencing. And then it would be appointments, and we would just start giving vaccine. We're not in that situation in this country, so we're going to do the best we can with the vaccine we have.
Zach, okay. Heath?
Thank you for coming in. Happy New Year. Hopefully it's better than the last one. Maybe we won't see you as much, but that's fine. Just curious, I know obviously there's been a lot of work in your department, CPHO, environmental health, and so on and so forth, and it's continuing, and we have budget coming up, operational budget. Have you been in discussion with the province as far as increasing your budget to ensure that the demand that's on you and your department and your staff is going to be seriously looked at?
I've not had any discussions about increasing our budget going into the next budget cycle. But I certainly recognize that all the different aspects of this COVID response, from justice and public safety and pre-approval travel, our border screening, our testing. I mean, it's covered a lot of aspects that some of which aren't directly in our office, but it's been a great deal of work by a lot of people. But it has put us in a position that we're able to be talking about easing up measures when the rest of the country is in a different part of a different place. But no, I have not had any discussions about that.
Heath?
Just back to a little bit about Trish. You hear this in other provinces, maybe other countries. Some of her question in regard to, has any healthcare workers refused the vaccination to date that you're aware of?
So it's a good question. I think there have been, from my understanding, a few healthcare workers, but not certainly not the majority. Some healthcare workers who've expressed some hesitancy. They weren't ready to go right when it was initially offered, and but then now we also understand some of them are like, well, now I think I'd like it. So that's good too, and really we won't know. And some of them, for whatever reason, weren't able to get it when it was first offered. They may have been ill. They may have decided that they would opt not to get it if they were pregnant. There would be some of those decisions on a sort of risk basis that they've chosen not to. But we will be looking at those overall rates in the weeks ahead.
Heath?
And just on the pharmacy side, I know we had the association in here, and they talked, and correct me if I'm wrong, but they said there may, I'm assuming they're in the first group of healthcares that to get the vaccination. I'm assuming that, but correct me if I'm wrong on that point too. But I believe they said there'd have to be regulation changes for them to distribute the vaccination, and I was just wondering if that has taken place, if that's correct. And has it taken place?
So the COVID-19 vaccine has to be added to the list of vaccines that they are able to administer. And so that we've spoken with the legislative person. I think it's gone where it needs to go in terms of making that regulatory change.
Heath?
My last is obviously we're coming up to a tourism season, and I'm just, and your obvious proof of immunization is very interesting, and I think that could really boost the economy of Atlantic Canada for sure. But we haven't heard much about rapid testing or anything in regards to travel and that sort of thing. And we did at the beginning of all this, and then it just kind of subsided. Did it subside because of the vaccinations now, or is there something? Is it not feasible to do it, or is it not worthy to do it, or just where did it go, I guess?
Rapid testing is a really good conversation that has, as you mentioned, has been with us all along the way. Rapid tests initially, and a number of the rapid tests do not have the sensitivity or specificity that we're comfortable with, and I think that's one of the challenges with them, especially when we have capacity using PCR tests. So when we talk to the lab, they're like, if we have capacity to do the PCR tests, it's a much better test. So we've that's where we've been able to use that PCR, and we've also been able to increase the turnaround time. So most people who are, if you get swabbed with a PCR test this morning, you would have your results back tonight. There are some what they're called, instead of rapid antigen tests, they're actually called rapid molecular tests. There's something called ID Now, and they have some better, slightly better sensitivity. And so we certainly are discussing where they're best used, and they're often, so that conversation continues, and I know there's more on the market for those tests. One of the concerns has always been, and I think we've talked about it at times, that if you do a rapid test on someone, and especially if the sensitivity is not that great, people think, oh, I'm negative, and they don't want to exercise the other public health measures that are in place. And we know that a negative test on one day, even with the best PCR test, doesn't mean you will not become positive on a day later. So I think there's been some challenges with that private test.
One more?
I'll let it happen.
Actually, it was just in relation to Nova Scotia is doing very well, and Prince Edward Island is doing very well, and New Brunswick's not, obviously. But has there been any thoughts or discussion on creating some sort of bubble within Nova Scotia and Prince Edward Island?
So it has been raised in the last week or so by a couple of people, and logistically it's really challenging because of how you get from Nova Scotia to PEI, and how the screeners would actually know who's been where. So I think it's something that we'll continue to look at. I'm not saying it's not won't be something to think about in the future, but right now, certainly not today.
Ola?
Thank you, Chair. It's a really impressive rollout. It looks like we're not going to have vaccines sitting on the shelves. I appreciate that. I just turned 79. I was considering instituting a personal leap year, so I've become 80. But anyway, my question was, in other countries, and you even mentioned yourself that the vaccine second shot could wait 42 days. Have you considered here on PEI, like doubling the coverage approximately by stretching it out?
So we have looked at what NACI has said, and also at the product monographs. They, certainly the advice is that they really do know from the initial trials, as much as possible, we should stay to those 3 weeks for Pfizer and 4 weeks for Moderna. NACI has said, well, you can extend it for logistical reasons, for epidemiological reasons. If we were having a situation even like New Brunswick, I think the conversation would be different. But we're in a position where we can really make sure we get our long-term care and community care residents fully vaccinated and fully protected fairly quickly. But if there is a delay, and I didn't speak too much about it, but if there is a delay for a couple of weeks of a vaccine coming in over the next couple of weeks, and knowing that we're going to get additional doses in March, that has been something that an option we would consider, trying to use the vaccine we have, extend the dose a little bit so that we continue to vaccinate islanders. So absolutely, it's on it's on our minds as a possibility, and we may need to do that if there's any kind of delay in getting the vaccine, even if it's just a temporary delay.
Ola?
Oh, I had one other question. You spoke about the vaccination certificate. What are you going to do about the people that already had COVID and presumably are immune as well?
So again, very great point, and we have been having those conversations nationally, and actually it's something that we've decided nationally to dedicate a little bit of time to, talking about the proof of immunization, but also proof of disease. So with 94 million people around the world having had COVID, there's some who said, well, maybe I don't need to either be vaccinated or I don't need to follow the measures in the same way. For the same reason that we don't know how long the effectiveness of the vaccine lasts, we actually don't know how long someone is protected once they've had COVID. And they are also finding with the variant strain that we're seeing in the UK and South Africa strains, and also out of Brazil, that people may be able to get COVID again. And so I think that is also going to play into it. So part of the discussion, but it's, and there'll be some blood tests, but that is not being recommended as an approach to have blood tests before you enter the country. I don't know if you wanted to say anything about any of this.
Yeah, as of right now, NACI is recommending that even if you have had COVID, you wait a period of time, 3 months after you've been diagnosed, and then you receive the vaccine. And that is because we don't know if natural immunity prevents you from getting COVID or prevents you from getting additional variants.
Thank you, Chair.
Great, thanks. Trish?
Thank you, Chair. So there have been reports from other provinces of wasting of vaccine, and I was just wondering, is that an issue here at all? And if there's any, if you have a sense of what percentage, if that has happened here.
We actually are really pleased to report wastage has not been an issue here, and they have been very diligent about it, and so we. And I think that was a report from Public Health Nursing, and they are very, they're very experienced at giving immunizations, and they were careful, and really there hasn't been the wastage. Again, I think that's certainly what we heard latest.
Yeah, we're happy to report that we have had very minimal wastage at all, partly because of the skill of the nurses. Anytime you have multi-dose vials, there is a chance because you're trying to get many doses out of the same vial, but we haven't seen that issue here. And I think as well, because we don't have some of the logistical concerns that some of the larger provinces have with moving vaccine under rigid cold chain conditions to rural and remote areas of the province, that we don't have to deal with onward flights, repacking vaccine that comes into the province from the freezer onto dry ice to move it around. So we are fortunate that way. So we haven't had any wastage from shipping.
Trish?
That's great to hear. Dr. Morrison, you gave a really clear description of the mRNA vaccines, which both Pfizer and Moderna are that type of vaccine, is my understanding. So that was really helpful. You've also outlined that as other vaccines are approved here in Canada, that they will be included into our vaccination process here as an option, or that we'll be using those. So are there vaccines that are different from that mRNA sort of model, and is there a difference in efficacy of other vaccines?
So yes, the other vaccines that are that Canada has negotiated some initial contracts with are not necessarily mRNA vaccines, and I think that's part of the information that will be submitted to Health Canada for review is around their effectiveness in their trials. And so, and we've already started to think, what will we do if the effectiveness is not the same as the mRNA vaccines? But that is, of course, something that the whole country is looking at. But and we know, for instance, our influenza vaccine certainly is not as effective as our the Pfizer and Moderna have shown to be, but we know it does reduce your chance of getting sick and being hospitalized, even if it's not 100% effective. So, but we'll be looking at that with the information that comes in. There's big submission packages to Health Canada about effectiveness based on their trials. You'd be really, Erin's worked a lot in the vaccine world, so I'll let her, you want to add anything to that?
I think when we think back, I mean, it wasn't that long ago where we were looking at some of the clinical trial data that was coming from Pfizer and Moderna, and Health Canada had a threshold of, we're not going to approve anything that is less than 50% effective. That's where we were in the fall when we were thinking about this. Lo and behold, to our surprise, I mean, the effectiveness is really high for both of these vaccines, Pfizer and Moderna, out of their clinical trials. We know that once you get into the real world, your population level efficacy can be reduced because people are different and more diverse when you start immunizing many, many people. So, but overall, I think we're very pleased with the level of efficacy that was demonstrated in the clinical trials, and so hopefully the next candidates that come along are very similar.
I don't know if I mentioned, after 2 doses of vaccine, the effectiveness is very similar, sort of over 92% for both Moderna and Pfizer.
Trish?
Thank you, Chair. And so that's, it's incredible and wonderful to hear that those 2 vaccines that happen to be approved first are so effective. That's great. This may be a stupid question, I'm not sure. But I'm wondering, if someone, when those other vaccines are approved, if there's one that's, let's say, 70% efficacy and we want to get everybody to get vaccinated as quickly as possible, if someone receives like a vaccine at 70%, can they later get the other vaccine so that they have increased protection, or is it one or that's it?
I don't think anyone has really addressed that at this point in time, but one of the things about if a vaccine comes on later that's not quite the same effectiveness, and those are general effectiveness, it may be really, every person's going to mount a slightly different response to a vaccine, so how effective one vaccine is side to side is always a challenge, but we know that for instance, our long-term care, community care facilities, those people who are older don't always mount the same immune response. So it will have been really important that they have the vaccine that is really highly effective to see if we can mount that response. So by the time a different vaccine has come on board, we'll know we'll have done some of our more senior populations.
One more question. Thank you. So there was a recent CBC article actually highlighting concerns from people who have underlying conditions and where they might fit in the rollout. So I'm wondering if you could elaborate on that a little bit.
And I did try to mention it, that we know that people with immunocompromising conditions, those with autoimmune disorders, pregnancy, are all addressed in an updated language around the use of the COVID vaccine in those populations in the most recent updated NACI. In terms of when they're able to get the vaccine, we are, again, focused a lot on age as we go into Q2, but we are conscious of if we can also consider those with immunocompromising conditions, but how we're going to do that remains under discussion. It's very hard in mass clinics when you have only a certain amount of vaccine that isn't being given by your own provider to identify someone who may have kidney disease or asthma, but it's easier to identify people if they're 70 years of age. So some of it is logistically, some considerations how we can try to get everyone done as fast as we can, and if we can go down in large chunks of age, that will be helpful. But having said that, we may be able to look at clinics that would be set up for people who may have immunocompromising conditions specifically. Those are the things that as we get more vaccine and know how much vaccine is coming, those would be all under discussion.
Real quick? Yes. Okay, so great. I'm just wondering, you mentioned you'll be using an online system eventually to sign up for clinics. Have you considered, or would you consider perhaps allowing people to self-identify if they are immunocompromised, and perhaps you could have a check system if needed, but just as a possible way?
Yeah, I mean, all those things are certainly being considered, and recognizing that not everyone will also be able to book online, and so there's always going to be options for them as well by phone. So those we're definitely getting lots of questions and individual emails from many. Erin, I don't know if you want to add to that too.
Yeah, and we're also looking at options for people to be able to call, because not everyone is going to want to book online or schedule online. So having a 1-800 number to be able to book an appointment, I think, will be important as well. So that will be part of the vaccine program rollout as we move into community clinics after we move on from facilities.
The same, just sorry to
Sure. Oh, yeah,
that and the same kind of issues about trying to identify people with underlying health conditions was an issue during H1N1, and so I mean we're familiar with that. H1N1 pandemic certainly a different look and feel because it didn't impact those in the older population like this pandemic has.
Zach?
Thank you, Chair. Is there a timeline, and maybe you did cover this for when the clinical trials, or have you heard from the national group if the AstraZeneca and Novavax and J&J, is there kind of a timeline? I think it might have been mentioned in phase 2 on the slide.
So we're anticipating that at least one or more of those vaccines will be available at some point in Q2, but the information from those vaccine companies is being submitted to Health Canada, and I know some of that is actually under review by the end of the month, or if it hasn't already started. So that review process takes a period of time, but if the approval is made for one of those vaccine companies, then they'll get things underway nationally, and then we would get, based on the Canadian contract, we would get then 0.4% of that allotment into Prince Edward Island.
Zach?
Thank you, Chair. And just one quick follow-up. Are those all double doses as well, or are those single doses, or?
AstraZeneca is a 2-dose regimen, and the J&J is 1 dose.
Thank you.
Good. Brad?
Thank you, Chair, and thank you very much, Dr. Morrison and Erin, for coming and taking time out of your busy schedule. I know that I've seen personally you guys working long hours, almost 7 days a week since last March. So I do appreciate you coming in, because I know communicating the message around and the information around everything that we've had to deal with the pandemic, but now, of course, the vaccine is so very important. It's great to see our friends from the press here, CBC and The Guardian, over here inside the gallery, for goodness sakes. I like that. But I was wondering, as MLAs, is there like a resource package, or is it just the website, or is there any direction you want to give us when we're communicating with our constituents, like a preferred method for us to direct them if they have questions? You've talked about it a little bit, and you mentioned many different ways, but if you're giving us directions to MLAs, things you want us to share on social media, these sorts of things. You're communicating in many different ways, which is great, but if there was one sort of source that you'd like us to use.
I mean, I'll see what Erin has to say too, but I mean, I think from my perspective, as much as possible to the website, because the Q&A is being updated. I mean, it's going to be an important source of information, and it has links to other national data as well. I think, I know our communications folks are planning some campaigns about vaccine, and really looking at the groups ahead, and wanting to address everything from vaccine hesitancy to just that promotion of the vaccine in PEI. So I know they're actively working on that, and we'll probably hear more, and as MLAs, you'll hear more from that communication side as well, and it'll be important. I know they've done, for instance, quite a bit of work on masks and some of the mask campaigns, and some of it will roll in now into more vaccine-related communications, and yeah, and also nice to actually see people. For me, I only get to hear their voices as well from a communications point of view.
Brad?
No, thank you for that. And I know that there's lots of different special interest groups, lobby groups. Like, for example, in my role as Minister of Education, the PEI Teachers Federation is reaching out, and of course, their questions are always along the line of the people they represent, where are they in line with vaccination. I just wanted to find out, like, as a Chief Public Health Office, are you getting those requests, and is that something that you're going to respond, directly to all those different groups that contact you?
So we are aware. We will respond to the requests that you directed to us. I don't think we've been able to respond to all the requests. Some of them are individual. We're trying to respond to them. I think I sent an email last night to someone who had emailed probably 2 weeks ago or 3 weeks ago, but so we will try to get back to them. Some of the emails or letters have come from different organizations representing a wide variety of groups. We may not get back to everybody, but we will try to at least acknowledge that we've received them.
Brad?
That's good. Thanks, Chair.
Ola?
I had one last question. We know the vaccines were approved based on studies, I think, involved around 30,000 people each, type of thing, and there wasn't any results for long-term effect because the study was too new. So my question is that particular group still being studied, and do we get updated data from them now to see that it lasts longer? And the other question is, now we're using literally millions of doses a week. Do we get data from that as well?
And I think it speaks to the earlier question, how fast will we know about the effectiveness and long-term effectiveness? And I mean, I think those initial trial groups will give us some of that information over time, as well as the millions of people who are going to be vaccinated or who've just been vaccinated. So yes, so that information is really key. It's also why it's important that our information is going into national. Our reporting is going in nationally, and for instance, if we continue to do some testing, even here in Prince Edward Island, after people have been vaccinated and they return from as rotational workers, for instance, from travel, we'll be able to say, yes, we know our vaccine has really worked very well. We're not getting anybody positive after they've had the vaccine. So really right across the board, they're going to be doing the same kind of work and to see about that effectiveness. So and given the volume of vaccine that's being administered across the world, that information should come more quickly than it would if it was a smaller number. I'll ask Erin to just see if she has anything to add there.
They are following the clinical trial participants for 2 years, at least 2 years after immunization, and not only to see how long immunity lasts, but also just to follow up on any kind of adverse events. Although 30,000 is quite a large number of people for a trial, much larger than you would have for a drug, a pharmaceutical, for example. So both Moderna and Pfizer did include various age groups and different ethnicities in their trials, especially the Moderna trial. And so we do expect that it is representative of a lot of the population, but we do learn more, and that's after a vaccine is approved to market. And we submit data just as much as the other provinces do in terms of any events that happen here. And we're doing some active surveillance. We're planning to work with Canvas, which is several of the other provinces are working with them too. So as part of our communications campaign, we will talk about that program where people will be able to participate in a survey with a healthcare professional to ask them how they're feeling at certain points after vaccination.
Hello?
Oh, I actually had one more question. The British and South Africa variants sound scary in the way they spread easily. So it seems like you should wash your hands now if you never did before. My question is, can you test for those here, or do you have to send that off?
So all our positive cases are sent off island and for sequencing, and so the sequencing is not done in Prince Edward Island. Really, all of it is done at the National Microbiology Lab, from much of the country, there may be some provinces doing their own, but it's and we're talking about that and how do we report some of these variants. And it's normal for a virus to get mutations and to have some variations. That's a normal part of a virus. And I mean, if there's ever been a virus that's been studied a lot, it's this COVID virus in the last number of months. So we're certainly detecting some of these small gene mutations. But what's concerning about the UK, South Africa, is the number of gene mutations that are all quite similar. Like 23, I think, mutations in the UK one, and they are concerned about the transmissibility of that variant.
Great.
Thank you.
I just have a couple questions, and mine goes back to at the beginning. You'd said 89% of deaths are people over 70, and you've talked a lot about the 70, 80. But when I look at the first round from December to March, and then that seniors 7 years of age will be in the second round, April to June. Those are the seniors I think that are most stressed. They're kind of in a kind of gap between the first phase and the second phase, and that's who I'm getting a lot of calls about. What would you say to that demographic about that kind of statement or question?
Well, I mean, I think when we talk about age, I mean, the other part of it is also the congregate living settings, which is also part and parcel of the morbidity, mortality associated with the older age group. So these are people over 70 who are in the community that are we're wanting to get to as soon as we can. And I think they're a group that I know will have good vaccine uptake. And they're also, they're very good at getting their influenza vaccine as well. And so it's just that we are looking at the living setting as well as the age, and trying to come down as fast as we possibly can, and make sure that we get OLA done as quickly as possible.
Exactly. And I just keep thinking about that. Like, is there an area that we could move to 75 or half? I know it has to do with balance. I mean, balance between the vaccine coming in and the rollout. And I just looked at the numbers in April, and I'm sure you're looking at that too. But that's a little bit of a concern for me. So.
No, I mean, I think NACI has suggested we come down in 5-year increments.
Yeah.
And when we initially looked at the numbers of people in Prince Edward Island in the community that were 85 and over, we actually felt like, I think we can start with 80 and over, and we will do it, assuming we have vaccine, and then we'll try to quickly come down to 75 and to 70.
Great. Wow. It's great that you came in today, and I think, does anybody have any other questions? Anybody? No? It's really, it's good for us to get this briefing and for Islanders and, continued, just, the Island's behind you and the work that you've done. So, so what we'll do right now is we'll take a quick short recess, and then we'll just come back to conclude our meeting. Thank you very much. Back to move on to number 4, which is discussion of scheduling, and we talked about this a little bit at the beginning, but they'll be back on February 10th. At that time, the committee on that day will have 2 sessions, if that's okay with everybody, because we have Brooks Roach and Hunter getting in that day to talk as well. So if that's okay with the committee, just make sure that that's in your calendar for February 10th. 2 sessions there. Sorry.
Clarify, that one hasn't gone, that notice hasn't gone out yet, but it'll be for the morning, just so that it's not, yeah, no.
Yeah.
Yeah,
Okay.
Chair, I won't be able to make the morning, but I'll find a sub, I guess.
Okay, perfect. regarding the committee's request to have a briefing on the expansion of in-home gambling and the effects of, especially during the pandemic, the CPHO does not have anyone with that title of addictions coordinator, but the clerk has been advised that Nora McCarthy Joyce, she's the community relations specialist with the Department of Health, would be a good fit to present to the committee. Thoughts or suggestions or on that correspondence we've received? That be okay? Yeah. Trish?
I don't know if this would be possible, but could we ask the Minister of Finance to come as well to share what was taken into consideration in the decision that was recently made by Cabinet? Who
Sure.
they consulted with and what?
So it's open for discussion. I see Brad Travers.
Yeah, thanks, Chair. So I think the last time we brought this up, we said, we're going to focus on the health and the wellness aspect of this decision, as opposed to the finance side, because I believe someone said, it was Heath that said public accounts is already looking at that side of things. So I think we should stick with the CPHO myself. I don't think we need to Minister of Finance in.
Perfect. Trish?
Yeah, and the reason I bring this up is, it was such a sudden decision. I mean, I don't know if others knew that was even in discussion or a possibility. So, why, there wasn't any public consultation. So, maybe there was a lot that went into this in the background. I don't know, as far as I can tell, not. So that's why I would like to have that information. But certainly it's open to the committee to discuss if they feel that's appropriate or not.
We might just, Brad?
Yeah, and again, I think we should focus in this committee on the wellness side of things. I let the public accounts, if they want to get into the timing and all that kind of thing, that sort of stuff. So I would say we've got the right person and we're heading in the right direction.
Perfect. And the only other thing I'd suggest that this committee covers a lot of different things and a lot of different groups. So it affects Islanders. So I would just say if we want to maybe put it to a motion or have a vote on it at this time, and move from there. Hannah?
Yeah, and I think we need to kind of keep that in mind, that the scope of this committee is health and social development and incorporates a really broad range of things that we've talked in here about housing, but it is also charities, it's human rights, it's emergency measures, it's Indigenous affairs, it's Francophone and Acadian, it's people with disabilities. There is a massive range in there, and so while I appreciate that we have taken a significant amount of time prior to COVID and afterwards, there are a number of other key areas that we haven't even looked at yet in this committee. And so I think we need to get some balance in here as well, which is just, coming back to the mandate of the committee being charged with matters that relate to this whole broad piece. If we're not sort of looking at that entire mandate carefully and giving, frankly, a large chunk of our time to disproportionately to just one area, then Chair, I feel that we're doing a disservice to the overall mandate of the committee itself, and I would just like to ensure that we do consider that when we're thinking about where our priorities, and not just of what's on the agenda, but the time that we give to things.
Great. Brad, thank you.
Thanks, Jerry, and I agree with Hannah on that. I raised that last meeting as well about how we haven't really dug into the wellness piece a lot, and I think we need to, make sure we cover off some of these other important areas, as opposed to really getting stuck sort of on the topic of the day. We should really look at the broad and long-term mandate of the committee and making sure we have these recommendations that are going to be long-lasting as well.
Okay. So at this time, I don't know if would you like to make a motion?
Yeah, I will. I think just to say quickly first that the unfortunate thing is that we are doing this backwards, right? So the committee is exploring or now looking into what the impacts of online gambling might be for Prince Edward Island in terms of health and wellness before after a decision's already been made by cabinet. So that's, I think, the part that I'm really stuck on, is that we don't know how that decision was made or why. And it really, all of those pieces should have been considered in advance. And if they were, then I would like to know that. And I think the public would also like to know that. And if not, then they need to know that as well. So I would like to move that the committee, request the Minister of Finance to come to the committee and present on the decision to allow online gambling and what the next steps will be for implementation in Prince Edward Island.
Okay. Yeah. Just make sure that. Sure. Second, Hannibal. I just want to make sure the clerk has it written down. Brad?
Thank you, Chair. I just wanted to speak to the motion and say that I think that this is not a good use of the committee's time in this case, given our mandate as committee, Health and Social Development. And I think this is best left to another committee like Public Accounts probably to pursue. I think there's other issues that are probably higher priority at this, especially when we're talking about the subject matter that the motion talks about. I mean, which are not strictly related to social development and health per se. They're more related to the process and how we got here, very politically motivated type things. So I would say let's stick with the Chief Public Health Office, which we already have on our agenda. And I think it really is a far-reaching thing to try and bring the Minister of Finance in to talk about process on this. And it's more politically serving than it is reaching towards the mandate of the committee. Like I really disagree strongly with this motion.
Thank you. Yeah. Well, Trish and then Zach.
So I would like to say that if it is the case that this government believes that we can look at something like online gambling simply through the lens of what income will come in through that, simply through that lens, without considering the impacts in terms of health and wellness and on our social programs and all of those other pieces, I find that quite concerning. And I don't feel that this is a topic that can be looked at in isolation, and nor should it be, because there are long-term considerations here. So that is concerning. That's all.
Thank you, Trish. Thank you. Zach?
Thanks, Chair. Would the person who was proposed, would they not be able to cover the wellness side of the new online gaming?
No, because it's a cabinet decision that was made already. So they would just come in and talk about how potentially that would affect Islanders through a gambling lens or a public health lens. So.
Okay, just from a public health lens.
Well, yeah.
Yeah,
Absolutely. Yeah.
which is for the committee, right? Like that's for.
Yes.
Okay.
Yeah. Brad?
Can we bring this motion to a vote?
I support debate there.
Sorry. Brad?
Thank you, Chair. So I agree with Trish on this point, which is exactly why we need to continue with having the CPHO representative to talk about the health, the wellness implications of this. I think moving to have the Minister of Finance is really outside of the scope of this committee. It's political pandering, and it's really not serving this committee justice, because I don't even think that's a recommendation. That I don't see recommendations coming out of this committee that would relate to anything the Minister of Finance has to say. I think that's clearly public accounts, and I would pass it over to that committee. If they want to have the Minister of Finance in, I think that's up to them. But again, I just disagree strongly with this motion.
Thank you. Trish?
Yeah, so understanding what the implementation process is expected to be from the Minister of Finance could absolutely lead to recommendations from this committee. And it would actually be quite difficult, I would think, for us to make recommendations without knowing what the plans are for implementation currently. So it would seem critical, actually, in that way, for us to have that information, to make recommendations.
Perfect. Great. Okay. Good debate. So at this time, is it okay? We'll take this to a vote. Ola cannot vote. So all those in favor of the motion as it stands, say aye.
Aye.
3. All those against, say nay.
Nay.
Okay. So the vote is 3-2. Motion passes. We will invite the Minister of Finance to speak about the decision in Cabinet to move forward with that. So we'll send a letter, and that might take, we'll try to get that done or find a time frame for that prior to the session, in end of February. Okay, so moving on, if this discussion of scheduling, and there was just that Jason Doran, he can't come in, or he declined the invitation, so. Trish?
On that, fair enough. So he had indicated that he didn't feel he had the expertise at this time to talk about that. So it would be good, though, to have someone else, another, academic who has done research in this area. So I don't know that we have anybody else on PEI who would be a good fit, but I would suggest we might reach out to Dr. David Hodgins from University in Calgary. Calgary U is what I have here. It seems to be, from what I've heard, a leading expert in this area, and see, and I'm also open to other suggestions, but, from the research I did, that he seems to be a good fit, and of course would have to be over Skype, but we can certainly do that.
Perfect, okay, great. So we will, we'll find the contact information. If the committee is okay with that, we will send a message. We'll ask for some feedback and potentially set up a Skype, over Skype potentially, if he's okay with that. Anybody else in this field? No? Okay, perfect. But we're open to that as we get going. So at this time, is there any new business? New business? No? Perfect. So could I have a motion to adjourn? Brad Trivers, this meeting is adjourned. Thank you.